Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of January 29th, 2024. After a status update on COVID, flu, and RSV, I will talk about long COVID. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It's still causing sickness, disability, and death, and there's still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look at wastewater sites nationwide, the light purple shaded area shows the most recent 2 weeks that have complete data. So that is late December, early January. And looking at the red and orange waves, we can see those are the percentage of sites that have increases and large increases in SARS-CoV-2 concentration. And we can see that those are decreasing for those most complete 2 weeks. The gray shaded area are the most recent 2 weeks, which are incomplete. Those take us through mid-January. And as you can see there, it does look like they might be going back up, but that data is incomplete. So it's just something we're going to have to watch and not draw any conclusions just yet. Weekly new hospital COVID admissions are finally coming down. We're at 26,607 hospital admissions for the week ending January 20th. And that was the second week in a row where we saw COVID hospitalizations coming down. So let us hope that that trend continues. Taking a look at deaths for the week ending December 30th, we had at least 1,978 deaths in the United States from COVID. And that was the fifth week in a row that deaths were increasing. And remember that deaths tend to follow hospitalizations by a few weeks. So we'll be monitoring to see if those death numbers start to hopefully come down. But right now, this is almost quadruple where we were for most of the month of July when we got down to around 500 deaths per week. Now we're almost at 2,000 per week. But hopefully we'll start to see those come down as hospitalizations come down. We'll just have to see if that is a trend that holds true as things with this virus continue to evolve. So here I'll give my weekly reminder that many of these deaths could have been prevented. First off, of course, by doing what we can to prevent the spread of SARS-CoV-2, also by being up to date on vaccination, and lastly, by accessing outpatient treatment as soon as possible after testing positive for all of those who should be treated. And if you are one of those people, you should know that now. Do not wait until you get sick to see how you'll do. That is not how this works. That is when things can end up going too far. It can be too late, and you can head into that next phase of COVID that can result in hospitalization and death, when instead we could just nip it in the bud by staying prepared and acting quickly. Now, taking a look at influenza in the United States for the week ending January 20th, 2023, and looking at positive tests on the graph there on the right, it looks like we are coming down. I certainly hope that continues. The week ending January 20th, there were over 12,000 patients admitted to the hospital with influenza. And the week prior to that, it was over 14,000. So that's a good sign, seeing that coming down as well. So far this flu season, there have been an estimated 210,000 hospitalizations, 13,000 deaths, and of those 57 were pediatric flu deaths. And again, many of these deaths are preventable with the flu vaccine. It's not too late to get the flu vaccine. It's recommended for everyone 6 months and up. Flu season pretty much considered to last like through March or so. And even though it looks like it's coming down now, there's no guarantee there won't be another bump up. That does occasionally happen during flu season before it goes back down for the remainder of the year. So something to consider. And taking a look at RSV nationwide, this graph continues to be a little confusing, but I think we should really only be focusing on the purple line, not the blue line. The purple line is regarding PCR detections, and there are just many more fold more PCR tests than antigen test numbers. maybe the antigen test numbers are just so small that they're not as relevant to look at trends, and for whatever reason they're zigzagging there. The PCR numbers being much larger, I think we should look to those to understand the trend, and that's the purple line, which does appear to be coming down, which is good news. Although it is still quite high, we've still got a fair amount of RSV circulating. And if you're in a high risk category, the RSV vaccine might be a consideration for you right now as well. And taking a look at variant proportions, not much to say here. This hasn't been updated since we reported on this last week. So JN.1 is very much dominant at about 86% estimated of our specimens. It's very mutated, very contagious, but so far our vaccines and treatments continue to seem to be working well enough against JN.1 and all the other variants that we are dealing with at this point. So you might be aware that there was a U.S. Senate committee hearing on long COVID. It was the Committee on Health, Education, Labor, and Pensions, or otherwise known as the HELP Committee. And they held a full committee hearing on addressing long COVID, advancing research, and improving patient care. And that was just on January 18th. And I think this is quite significant. I thought it was very telling that not only did they have this hearing, but that several senators, not just those on the committee, attended this hearing. They asked a number of questions. They tied it to a number of broader issues within health and the healthcare system. And they also shared a number of personal stories. And if this is a topic that is of interest to you, I really recommend you take 3 hours and listen to the entire recording. It's linked in the post. I'll be sharing just a few highlights today, and I'll actually be sharing more highlights in an upcoming briefing, and I'll touch on that in a bit. But first, I wanted to start with Dr. Ziad Al-Ali, whose research I have reviewed here several times, as he has led some of the most important studies describing long COVID, as well as the impact of repeat COVID infections. And he really has emerged as a very strong advocate for accelerating and improving research on long COVID and post-COVID phenomena. So let's hear from Dr. Al-Ali.
Now, long COVID represents the constellation of long-term health effects of COVID-19. It is a multi-system disorder that can affect nearly every organ system. It affects the brain, it affects the heart, it affects the endocrine system, it affects the immune system, it affects the GI system. Long COVID affects at least 20 million Americans. It affects people across the lifespan. We have kids with long COVID. We have people who are 100 years old with long COVID. It affects people across the lifespan and across demographic groups. The burden of long COVID, the burden of disease and disability from long COVID, when you measure it, is on par with the burden of cancer and heart disease. And even if people emerge unscathed after having the first infection, they can still get long COVID after reinfection. And I don't think enough people really know this fact or know about this. Recovery rates of long COVID are also low. Between low rates of recovery from long COVID and the cases that are due to reinfection, we are supposed to see continued rise in the burden of long COVID until we find better ways to prevent it and treat it. Now, you should be asking me now, how do we prevent long COVID? Well, the best way to prevent long COVID is to prevent COVID in the first place. There is actually no long COVID without COVID. You know, if you go back to 2019, you go back to 2018, none of us have heard of long COVID. Have you? You haven't. It didn't exist. There is no long COVID without COVID. We need a sustainable, multi-pronged approach to prevent repeated infections that would be embraced by the public. This requires accelerating the development of oral intranasal vaccines that block infections. This is very, very, very important. Ventilation and air filtration systems are also very important. They can play a major role in reducing the risk of transmission of airborne pathogens. We also need variant-proof vaccines. What the virus is doing is really continuing to mutate on us. You know, every few months, you're going to see a new variant. We need a variant-proof vaccine that lasts for a long time, that is durable, that offers durable immunity. Now, you should be asking me also, like, how do we treat long COVID? You've heard it before. There are zero approved medication for the treatment of long COVID. So these people have nothing to really lean on for curative treatment, nothing, zero. Zero FDA-approved medications for the treatment of long COVID. This must change. We really need to change this. It's not beyond the might and the prowess of American medicine to solve this problem. It's absolutely not. We've solved much, much harder problems in the past. We just need to focus on this and solve it. We are the best nation on earth, and we can solve this.
And I will recap on some of this in a moment, but first to the initial point around 20 million people in the United States suffering with long COVID. I wanted to point out that the National Center for Health Statistics, as part of an ongoing partnership with the Census Bureau, has actually put forward questions to assess the prevalence of long COVID on what's called the Household Pulse Survey. And we know that, of course, surveys are not perfect, but it does give us a pretty broad indication of the percentage of adults in the United States who've ever experienced long COVID, so symptoms that lasted 3 months or longer, and the percentage of US adults who are currently experiencing long COVID. They've been doing this since June of 2022 and have also added more specific questions about activity limitations as well. So it's a good resource to get a sense at the population level in the United States of the burden of long COVID. And the link to this resource is in the post.
This essentially shows our national estimates of what percentage of the population has experienced long COVID or is currently experiencing long COVID. So here we're looking at the percentage of adults who have ever experienced long COVID. And we can see here that this has been sort of around the 14 to 15% range since they started tracking this in June of 2022 of adults who have ever experienced long COVID. And if we look at data on those who are currently experiencing long COVID as a percentage of all adults, you can see looking across this top row here that we are looking at somewhere in the 5 to 6% range. And so that is where we are coming up with these estimates around 20 million people currently affected by long COVID, or 5 to 6% of the population. So this is really quite significant. 1 out of 20 people or so that you might know could be experiencing long COVID. So this is pretty significant. You can look by state as well. So this is basically showing the percentage of all adults that are currently experiencing long COVID. Where I am here in California, we can see that 5.5% of all adults are currently experiencing long COVID. Oregon has 6.8% of their population currently experiencing long COVID. And of course, we know from last week that Oregon and California are the 2 states that have recently decided to go down to essentially a 24-hour isolation period. So that is really at risk for more infection, repeat infection, more long COVID. And so this is obviously a major concern. But if you're interested in taking a look at your state, we can see that Tennessee is up at 8% of their adult population experiencing long COVID. So this is really getting quite significant in terms of a portion of the population that could be experiencing impacts on any organ system, but really could be having memory issues, concentration issues, and so on. And I think at this point, most of us have someone in our lives that we know that is experiencing long COVID.
And remember, those numbers are percentage of the entire population. So this does not actually tell us what percentage of COVID infections lead to long COVID. That would be a higher percent, because this 5-6% is actually of the total population currently experiencing long COVID, and the 14-15% is of the total population that has ever experienced long COVID. But since not every single person in the United States has had COVID, we know that the percentage of people who get COVID who then end up with long COVID is going to be higher. There's a whole range of estimates anywhere out there from 5-6% to upwards of 30%. I suspect that as time goes on and we better understand the risk factors and all of the mechanisms that lead to long COVID, that we will be able to refine this. But with more and more people getting COVID each day, this is something that will continue to increase in terms of the overall burden we are facing from long COVID. Before I share a little more from the hearing, I want to briefly touch on this study that was published in Science on January 19th, 2024. This study followed 113 COVID-19 patients for up to a year after they got infected with SARS-CoV-2. And at the 6-month follow-up, 40 of those 113 people ended up with long COVID. So in this particular study, and this is a small study, but in this particular study, 35% of the people who had COVID still had long COVID symptoms at the 6-month follow-up. And then what they did in this study was to assess all of the patients with and without long COVID with blood draws that measured over 6,500 different proteins in the serum. And what they found is that the patients who had long COVID compared to those who did not have long COVID demonstrated activation of a certain part of the immune system. And this part of the immune system, which is called the complement system, kind of targets pathogens or viruses and damaged cells. And as a result, patients with long COVID showed more tissue injury markers in their blood as well, and more signs of inflammation, and also increased antibodies against certain herpes viruses, including Epstein-Barr virus, which we know is associated with chronic fatigue syndrome. And these findings are significant because this gives important clues on how COVID infection could be leading to long COVID. This gives us some hope that we'll have laboratory tests that we can do to assess and hopefully diagnose long COVID, which is a huge gap right now. We wish that all primary care doctors could just have a panel of tests that they could just order and we would know that a person has long COVID, but we just are not there yet. But this study gives us hope that we are further along the way to that. And it also can give some clues as to the treatments for long COVID, because if we understand all of the mechanisms, then that should hopefully lead us in the right direction for treatment as well. And this really is where we need to be moving quickly as it relates to COVID. We need to hurry up with ways to diagnose it and ways to treat it. And to paraphrase something that Dr. El-Ali says, we need research efforts that match the scale and the urgency of the problem. And that, of course, includes treatment trials. Next, I want to share a little more of the Senate hearing, and specifically what was shared by Senator Kaine. I thought this was significant because he acknowledged the disparities we're seeing with long COVID and the importance of allies and those in positions of power speaking up.
Two other colleagues, one a former colleague, Senator Inhofe, and a current colleague, Senator Young, we wrote a piece about our own experiences together that I'd like to introduce into the record, if I might, Mr. Chair. And the reason that we wrote it is, Ms. Vasquez, you pointed out, and I think subsequent testimony is underlined, long COVID is disproportionately affecting people of color. Long COVID is disproportionately affecting women. But, you know, we're three white guys. One got long COVID in his 40s, Senator Young. One got long COVID in his 60s, Senator Kaine. One got long COVID in his 80s, Senator Inhofe. And we decided, after kind of finding ourselves on the floor of the Senate, bumming around and wonder if anyone else is having this weird experience we are, we found each other and shared our experiences. And I think the reason that we all started to be public about it is we didn't like that you weren't being believed. I didn't have trouble getting believed by a doctor. I didn't have trouble getting believed by a doctor. And I don't think Senator Inhofe did, and I don't think Senator Young did. Our physical reports of our own conditions were given credibility, but so often with women, that's not the case. With minorities, that's not the case. With young people, it's not the case. We've seen the similar phenomenon in maternal mortality when we've had hearings about this. And so we decided, the three of us, to talk about our experiences so that people would understand they're being believed. And Mr. Chair, by doing this hearing today, we can approach some substantive improvements, but also I think doing a hearing like this has a way of sending a message that people are believed.
I was especially impressed that Senator Kaine tied this issue to disparities that we are seeing in maternal health outcomes, which I've reviewed on this briefing in the past. But it's encouraging that maybe this is a new day where we're finally getting recognition of longstanding health disparities that have plagued us for far too long. So to kind of recap here, 20 million Americans are estimated to be affected by long COVID right now. Any and every organ system can be affected by long COVID. Long COVID affects all ages, children, adults, all demographics, all races, ethnicities. The burden of disease and disability from long COVID is on par with cancer and heart disease when you look at the magnitude of it. And long COVID can emerge after the first infection or the second infection or the third infection or after any infection. So infections and reinfections keep happening. So long COVID can emerge all the time, anytime, in people who get COVID. Recovery rates are low and we have zero treatments. So even though I am encouraged by this attention from the federal government, we have a long way to go. And we really need to understand why long COVID occurs and really why post-viral chronic illnesses in general occur in some subset of the population. So we know that there are some chronic illnesses that can follow a acute viral infection, and we don't really know why. And this has been ignored for way too long. And we are getting more clues about this every day. So I hope that is a silver lining of this pandemic. We need treatment. We need treatment trials at the appropriate scale and with the appropriate urgency. And in the meantime, we need to prevent COVID infections, prevent COVID reinfections, because as Dr. Al-Ali said, there is no long COVID without COVID. So what can be done at this level about prevention? So let's hear a little bit more from the Senate hearing.
We are going to get other pandemics, there's no question. For some reason, Congress doesn't seem willing to fund the basic preparation for to be prepared for that next pandemic, which we're still working on. Well, I do believe we'll get there. But should we also be looking at considering changes in some of the guidelines we issued for transportation? How many air changes we have in an elevator or in an airplane, whether the new air comes in high or comes in low, buildings, how often the air changes. Is that, now that we're beginning to understand this type of pandemic and knowing we'll get another, shouldn't we be considering more carefully how we build things in the future?
Yes, yes. So investment in air filtration and in ventilation, air filtration systems is going to be very, very important. Updating building codes to actually require them is going to be very important. Let me give you an example. We actually, earthquake-proof buildings for earthquakes that happen once every 50 years or 100 years. We invest millions of dollars in making buildings earthquake-proof or seismically proof, right? Why can't we do the same thing to really make sure that our buildings are proof against natural hazards like airborne pathogens, right? So this is very, very important. One of the lessons that we learned from this pandemic is that pathogens could be transmitted in the air, like SARS-CoV-2 or airborne pathogens. And the one way to protect or to reduce the chance of transmission and infection is to clean the air in indoor buildings. And one of the pathways to do that is investment and updating building codes to require better ventilation and air filtration systems. There are studies demonstrating that actually kids perform better in schools when they have better air filtration, air ventilation systems. Like they actually perform better in schools. That's really been done.
So clearly what Dr. Al-Ali is talking about here is going to take a lot of work and intention and investment, but it can be done. And it can help. These changes in building codes and in how we are thinking about ventilation and filtration can help not only with reducing transmission of SARS-CoV-2 and other viruses like flu and RSV, but it would also help us be better prepared for future pandemics. And there are also other benefits such as improved concentration and improved performance of students in school. Last week, I talked in detail about California's dangerous decision to eliminate the 5-day isolation period for those who have COVID. And I especially emphasized my concerns as it relates to schools. And if we'd already made the kind of investments that were discussed in this Senate hearing, then perhaps this wouldn't be as dangerous of a decision, but clearly that is not the case. So if you want to hear more about that decision and more about why it's such a dangerous one, especially as it relates to our schools, please check out last week's briefing. But today I did want to add that there are efforts going on to reverse that decision, including some phone banking, and I've linked information about that in the post if you would like to get involved. And in the meantime, contrary to what that guidance seems to be indicating, testing for SARS-CoV-2 remains an important tool in our armamentarium to prevent the spread of SARS-CoV-2, which will in turn reduce not only hospitalization and death, but also the incidence and the overall burden of long COVID. So why test? Well, first, we can prevent spread by excluding those who test positive from our gatherings and our events. So this is an added layer of protection pre-gathering. Also, testing is very important if you would need to be treated if positive. And this also includes if you went around people and spread it around to people while you were contagious who need to be treated. Because the sooner we know that you have COVID, then the sooner we can treat with antivirals, which really need to be started as soon as possible. And you want to test in order to warn those that you've been around for the preceding few days that you potentially spread it to. And then you also want to know so that you don't spread it to even more people. And last, but in our opinion, not least, we should be testing to exit isolation. In general, enough to detect is enough to infect when it comes to our antigen tests. And if you haven't received your free COVID test from the US government, please order those. The link to that is in the post as well. And remember, if you do get COVID, please don't push yourself. Allow yourself the time you need to fully recover. And this goes for when you have the acute infection. So when you're sick, please don't push yourself. This is another reason why we don't agree with eliminating the isolation period. I think we've all probably been guilty of trying to get back out there too soon after being sick. And it's really something I had hoped would change about US culture in this pandemic, but unfortunately that does not seem to be the case at all. Remember that there is some correlation with not resting and later having long COVID. I have a lot more to learn about that, but word to the wise, resting and recovering is a good thing. There's a lot more I want to say about this, including how pushing yourself and exercising is generally not a treatment for people with long COVID, is actually contraindicated or specifically not recommended in many cases, which I'm going to review in a future briefing. And at that time, I'm going to share more of the Senate hearing and share some clips from some of the amazing patients who said much better than I could some of the things that I think are important for us to understand about long COVID and the treatment or the management of long COVID, as well as some important lessons about long COVID advocacy and just advocacy in general. So I will look forward to covering that very soon. And remember, we want to continue to do what we can to avoid infections and reinfections. Catching COVID once and doing fine is not a guarantee about the next time. Every infection is a new opportunity, perhaps even a compounded opportunity for long COVID and post-COVID impacts. So let's please keep up our best practices to prevent the spread of all respiratory diseases, but especially COVID, and to prevent long COVID. Vaccinate, wear a high quality filtration mask indoors, gather outdoors whenever you can, pay attention to that ventilation and filtration indoors. And as usual, let's pay attention to our overall health and well-being. Eat a balanced diet, avoid processed foods, avoid sugary drinks, get some regular physical activity unless you're not feeling well. In that case, please get your rest. And if you're someone who should be treated if you get COVID, you should know that now. If you don't have a primary care provider, please get one. Know how to reach them before you need them. Get your baseline labs checked, your blood pressure, and so on. And remember to manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you again next Tuesday at 10 a.m.